So thanks to Eva Oniukka and Filippo Schiavo from the Karolinska Hospital for guiding us in this webinar on models to estimate the risk of normal tissue complications after radiotherapy. Eva leads the research team for medical physics in radiotherapy and is an associate professor at Stockholm University. In Tetris, she leads work package 2 on long-term side effects modeling. Filippo earned his PhD at the Karolinska Institute and is now a postdoctoral researcher at Karolinska Hospital working on the work package 2 in Tetris. After this very short introduction, I would like to leave all the time to Eva and Filippo. So Eva, you can start sharing your screen.
Perfect. Can you see my screen?
Yes, perfect.
Great. Thank you, Tiziana, for that kind introduction. Thank you. I'm going to start off this sort of educational session on models to estimate the risk of normal tissue complications after radiotherapy. This half hour will be followed by Filippo, who will talk more specifically about these models and how they are used in the Tetris project. Let me see if I can get this there. So we're speaking from a very wintry Stockholm, and it's really nice to know that you are joining us from all over Europe, probably warmer places. But it's an opportunity to familiarize ourselves with the basic concepts of predictive models in radiotherapy and the role of these models in the Tetris project. And Filippo will also go into model performance metrics, which we need to consider when we choose which models to use in our project. Radiotherapy, as probably most of us are aware, act by causing cell death of the tumor cells, and that is the aim when we treat with radiotherapy. But as the beams also pass through normal tissues and organs, there can be loss of function also in the normal tissues. And this is what we want to minimize as much as we can while still treating the tumor to an appropriate dose. Symptoms are typically on an organ level, and there, when we look at the symptoms for a patient, we cannot easily link that to the exact cell kill that is the underlying cause of this damage and these symptoms. Instead, we use sort of global scales, often clinician-reported scales of side effects, and the common ones are the CTCAE, RTOG, EORTC, and the Lentzoma scales. And these, I will show you an example on the next slide, what it can look like. But increasingly, we also collect patient-reported outcome to describe the symptoms or quantify the symptoms that may follow from radiotherapy. Here you see the CTCAE cardiac effects table, where you can see how the grade of side effects range from 1 to 5, or 0 to 5 if we include the no effect option as well. So it goes from mild effects, number 1, to moderate, severe, life-threatening, and fatal. 5 is also always fatal. So it's there are these discrete categories that can describe the symptoms that the patient might experience. So the scales are not continuous, and all the steps may not be comparable in effect. So comparing grade 1 to 2 could be a smaller difference or a larger difference compared to if you compare 3 and 4, for example. And this means that we can't treat these outcome data as continuous values. And instead, we treat them typically as a binary outcome, for example, grade 2 or greater brachial plexopathy, as in the figure here, as an example. Here we studied patients exposed to SBRT treatments, and we looked at the dose to the brachial plexus, and the red crosses at the top show what dose was given to these patients, to the organ of interest. And instead, the green diamonds on the bottom show what dose was given to the patients who did not have this side effect. So our job then with a predictive model is to capture this evidence into a model that we can use to predict the risk of such a side effect for future patients. And when we have a binary outcome, the natural choice is to use a logistic regression model and create a normal tissue complication probability model based on such a structure. Then the outcome is also typically rated at a particular time, for example, 2 years after radiotherapy, or sometimes say the highest recorded grade over time. The logistic regression model is a generalized linear model which combines the log odds of all predictors. And we use, or we describe dose as a predictor, but there could also be non-dosimetric variables that we want to include in the model that are also important for the risk of such side effects. Patient-specific clinical variables, for example, or maybe age. And these can all be combined in this rather simple expression where beta 0 is the intercept. So that would be the intercept where the sigmoid curve cuts the y-axis, followed by a number of predictors, x, with their coefficients. And the coefficients indicate the effect size of each of those predictors on the prediction. So it's a rather simple computation, and it's available in many statistical packages. And this has made the logistic regression model very common as a structure for normal tissue complication probability models. Now, the complication or the complexity when we use when we look at radiotherapy data is that the word dose or the concept of dose is not straightforward. In modern radiotherapy, we build the dose to the target through many different beam directions, and that results in a very complex 3D dose distribution in the surrounding normal tissues. And then that means that each patient has a unique distribution of dose in the normal tissue. So we have a very simple outcome measure, just say 0 or 1 as labels. And we have a very complex input measure, being this 3D dose, that we need to work out in what way we can give that dose safely and what particular distributions of dose would imply a greater risk. Another difficulty is that different organs and tissues in the body respond differently to different aspects of the dose distribution. And this has been considered historically through breaking down this inhomogeneous dose distribution into more simplified scenarios. So if we consider instead like this very complex 3D dose distribution, we consider a uniform partial organ irradiation. So let's say that we would expose the lung to like a third of the lung would be exposed to a certain dose. Then we could in principle plot the risk associated with that. So as we give a third of the lung volume an increasing amount of dose, that would increase the risk. So the risk is shown here on the z-axis. Well, if you would keep the dose constant and instead increase the volume exposed, you would similarly increase the risk of complications as we increase the volume exposed to that particular dose. But in some organs, increasing the volume doesn't greatly increase the risk. Instead, it's the, say, maximum dose to that organ that is important, and not so much how much of the volume is exposed. And that can be understood through the functional reserve of an organ. We know that the pulmonary function can prevail even if you perform resection of a lobe or maybe even a whole lung. And similarly, if we destroy part of the lung tissue, we could have preserved pulmonary function, and that's because there's a functional reserve in this organ. Well, that wouldn't be the case for the spinal cord, which is a typical example of the opposite, where if you destroy, if you damage the spinal cord somewhere along its length, the whole function might be lost as a result. So that illustrates how different organs have different functional reserves, and therefore also differently sensitive to the volume of radiation that they are exposed to. There are also other effects that influence the volume effect, like how far cells can migrate in certain tissues, or possibly a stochastic element where exposing more cells or units to radiation could increase the risk of any one of them being destroyed. And also an inflammatory response might be stronger if a larger volume has been exposed to radiotherapy. But what we typically consider for the volume effect is this functional reserve and how different organs can be different in that sense. So that's a very sort of schematic way of considering a dose distribution, that you would have like a partial organ uniform dose, and that doesn't happen in modern radiotherapy, to be sure. But what we do look at instead, through simplification, is a dose volume histogram. So we convert this 3D dose distribution to dose volume histogram, and then from there we can convert this to a summary metric that would take the volume effect into account. So if we know that we're dealing with an organ with a large volume effect, we would increase the risk if we increase the irradiated volume. And then it's appropriate to look at, say, the mean dose to the organ, or the volume exceeding a certain threshold dose. For organs with a small volume effect, instead, we would look at the maximum dose, or some sort of towards the top of the DVH. We can also, instead of making a priori decision about what we think that the volume effect is for a particular organ, we can infer it by fitting a summary measure to the data, just as we fit the, say, logistic regression parameters. And this metric called equivalent uniform dose was introduced by Niemierko a long time ago, and this has been used a lot in radiotherapy. You can see in the expression that the equivalent uniform dose, which by the way is supposed to represent the dose given to the whole organ uniformly, that would give the same risk of complication as the actual dose distribution. And you can see that in this expression, the dose in each bin in the dose volume histogram is weighted by the amount of the tissue, so the fractional volume that is exposed to that particular dose. And also this N parameter decides how much the dose is weighted in relation to the volume component. So for large value of N, the dose is the volume dominates the expression, while if N is 0 or approaches 0, the dose will dominate this expression. And N equals 1 also makes this expression reduce to the mean dose. So for an organ with a high N value, there would be a large volume effect, and the EUD would be the same as the mean dose. While with a smaller volume effect, N would be small, and then EUD would go towards the maximum dose. So we can use this function to also let the data tell us what value of n would give us the best model. So in summary, so far, we start off with this 3D complex dose distribution in an organ or multiple organs, and we can calculate those volume histograms for each of those organs. And then we can use a summary measure like the equivalent uniform dose to simplify or represent the full 3D dose distribution in that organ. And that allows us then to use this standard logistic regression formulation to estimate the risk of normal tissue complication probabilities for a given value of this summary measure. Here I want to explain how you can fit such a model to a clinical data set. So here's a hypothetical data set where we have collected, say, for example, the mean dose to the lung for 12 patients, and we have recorded whether they suffer from radiation pneumonitis grade 2 or higher, for example. And then they get a label of 1 if they have the complication and 0 if they don't. And we can use the maximum likelihood method to fit an NTCP model to this data set. And this is done by this expression, which is the maximum likelihood function. And the idea is to, for each patient I, Q is the outcome. So it would be 1 for patient 1, while it would be 0 for patient 3. And for each combination that you could or you would want to test for the parameters of the model, you would calculate NTCP. So you sort of loop through a lot of alternative formulations of your NTCP by using different values of beta 0 and beta 1. And for each of those alternatives, you would calculate NTCP for all the patients. And if the outcome is 1, that means that if we get a high NTCP with that particular parameter combination, NTCP would be high for patients with a certain outcome. And this would be 0 because 1 minus 1 is 0. Sorry, this would be 1. So we would be left with only that term. While for patients with an outcome of 0, so those who didn't have a complication, we would lose that term and instead this would remain. So this term would then also be high if NTCP is low. So this P, the maximum likelihood value P, is the highest where NTCP is high for patients with a complication and low for patients with no complication. So this expression finds the combination of beta 0 and beta 1, which makes our data set the most probable to observe. So it's really an optimization problem that can be done quite easily, and it's available in statistical packages. I want to also mention, apart from the logistic regression model, I want to mention a couple of other models which have been used historically, and also the LKB model is certainly used still today. So this model was formulated by Lyman first as a more simplistic case, and then Kutcher-Berman added the way to address the volume effect and not just consider uniform dose. So it's referred to as the LKB model. And it has been very popular, and it uses a cumulative normal function, so a probit function rather than logistic regression. It's very similar in appearance to the logistic regression model. It produces a sigmoid curve, but then based on the normal function instead, and therefore it has these two parameters, which are the sort of the mean value and the standard deviation characterizing the function. And this summary measure, which I have written as phi here, 550, it's often referred to as TD50, meaning total dose resulting in 50% risk. And that's a very intuitive measure. It's something that can tell us something about how sensitive the organ is to radiation. So I think that's one of the attractive features of using the LKB model, that we have also become quite used to these parameters TD50 and M that we often see in publications. On the other hand, the formulation is a bit less simple than the logistic regression function. But in the end, both of these model structures, if you fit them to the same data set, would give you very equivalent NTCP estimates. And it doesn't, the most important aspect is how you account for the volume effect. So if you would use, for example, EUD as summary measures in both, you would get very similar results, whether you use one or the other. The other, perhaps a bit more historical model that I want to mention is the relative seriality model. This is founded on a more mechanistic understanding of how cells and tissues respond to radiation, and it uses like Poisson statistics to calculate first a risk histogram. So for each dose spin in the dose volume histogram, it calculates the risk of local damage given the dose given in just that volume. And here the parameters, sorry, D50 and gamma might say something about the radiobiology of the cells, or at least some local units of the tissue. That is the idea. And then from that histogram of assumed damage, you would calculate NTCP with this function, which would scale related to how serial or parallel the organ is. And this is related again to the volume effect of the organ. A serial organ is one that would be fully damaged from any one small part of it being damaged, while a parallel organ could have some redundant function even after some of the partial compartments have been destroyed. So this the attraction here is of course the mechanistic rationale of the model, where we seem to be able to learn something about the mechanism of this damage. But when we fit such a model to a clinical data set, we have no guarantees that what we find in terms of parameter values really says anything. We don't really know what they relate to. So when fitted to a data set, it becomes as empirical as any of the other models, because we don't really know what those parameters would represent. And also the model that you produce by fitting it is very similar to the LKB model when you then apply it to another patient in the future. So maybe I would say that I've seen that it's become less popular than over time, and I think that's probably partly because it's a bit less convenient to use than, for example, the logistic regression model. And also, I'm not sure how we would use this model to include other variables. So if you want to make a multivariable model, I'm not sure you could accommodate that in the relative seriality model. So this is a quick walkthrough of the sort of basics of the NTCP modeling, and now just bringing that into the context of Tetris. So Filippo and I work in work package 2, and the main aim of Tetris is to support personalized follow-up of breast cancer patients, and we know that patients who have been treated with radiotherapy, it's very important to them to have information about possible risks for the future, how their life might look like with time, as they might have side effects from radiotherapy or some other events. And if we can provide such personalized information, that can also guide the follow-up of breast cancer patients in by healthcare. Often general practitioners also lack the detailed information about the therapy and what side effects they might or might not expect for an individual patient. And this is the gap that we want to address with Tetris. And in work package 2, we want to we will provide predictive models to integrate in a software tool to estimate the risk scores for individual patients, which could then be used for such personalized follow-up. And it's Aquilab, our French partner from work package 6, who will be developing this software, and we will then provide these models, which will be used for those predictions. And we will also at a second stage introduce imaging, genomics and transcriptomics risk features in the models, which we will get from other work packages in Tetris. The predictive models we look at are related to severe late side effects, and they have been collected from the literature relating to cardiac effects, pulmonary effects, and secondary cancers, because these are the severe late side effects that we can expect for some, well, a minority for breast cancer patients. The models will also be tested in a retrospective cohort that we have access to within Tetris. These consist of 2,000 patients from the Required and Rad Precise projects, which were prospectively followed up, and also 3,500 patients from real-world cohorts from the Tetris consortium. So thank you for the attention, and I will hand over to Filippo, who is going to explain more about the particulars of how our work in work package 2.
So thank you, Eva, and thank you, Tiziana, for hosting this webinar. Indeed, I'm presenting the part about the selection strategy that we are applying in Tetris. Yes, in Tetris, we are trying to determine a risk scores that should be communicated to patients, breast cancer patients, and basically we derive them from NTCP models. And we thought we can get these in 2 ways, either by selecting the models from the literature and then test on the retrospective Tetris cohort that Eva just mentioned, or we can also develop an in-house model by using a so-called meta-analytic approach, also called master model approach. I just described this second briefly, as the main part of the presentation will regard the first type of strategy. So let's say we have an NTCP model for an endpoint, in this case a dyspnea. We have this formal model where instead of using the logistic regression, we describe the model with parameters of the curve that you saw in the plot. So this gamma would represent the steepness of the curve, and the D50, the dose at 50% complication probability. And then as predictor, here we have the mean lung dose. So the mean dose given in terms of radiation to the lungs. And what we could do from this is to add some quantities called odds ratios. We can fetch them from the literature. In particular, they would refer each to a specific predictor. Let's say OR1 could refer to smoking status, if the patient is smoking or not. OR2 to the BMI, we could discriminate for those patients that have a BMI over certain threshold, like 25 or so. So if the patients present these predictors, so if, for instance, they're smoking or if they have a certain BMI, then we apply these odds ratios. And odds ratios are size effects quantities, so they tells us how much a predictor impacts on the final outcome, and we can find them from the literature. for specific endpoints. And here the difference between these and these is also that we would use the gamma and basically use a curve that is based on a population that doesn't have any of the predictors here. But I will focus now more on the first strategy. So we start by making a comprehensive review of all the models available in the literature. And after that, we make first a qualitative assessment. So we try to understand which ones have the basic requirements that we need. So we check for the completeness of the description of the model, if all the coefficients are present, if the methods are described in the patient cohort, and so and so. And after this, we then quantify these models in terms of performance. And we do this on the retrospective Tetris cohort. We can use this either the metrics they report or use our own metrics. So we decide which are the best performance metrics that could be useful to compare all the models among themselves. Also, after this, we assess the effect of certain clinical predictors across all the models. So we check that the data about the predictors are consistent, or if there are like differences or discrepancies between models. If the size effect, for instance, is different from a model to another. And eventually, we also test all the models on individual patients, or at least some of them, just to check if there are even here discrepancies among models in terms of evaluating specific cases. After this, we rank these models according to these performances and these assessments. And we do this for every endpoint. The endpoints, as Eva mentioned, regard the lungs, the heart, and the second primary cancers. For instance, here I mentioned the lung fibrosis for the lungs, the coronary artery disease for the heart, but could be many others. So far, 23 studies and even more NTCP models were identified. And a qualitative assessment is being performed based on factors like cohort size, the type of model used, because the logistic regression is not the only one, also LKBR and the relative seriality, they're not the only ones. Based on the endpoint incidence found by the study, the predictors used, etc. We then compare models quantitatively. So let's say we have these patients on the 0 bar and the 1 bar, representing those that don't experience a secondary effect and those who do. And these are ordered by doses received by specific organ that is being considered. Then we make a model. We use logistic regression or other models to give the probability for each level of dose of the outcome. In this case, for instance, for this dose, we have 50% probability of getting the outcome. And then from this model, we can predict the outcome on new patients. Let's say we have the blue and the green one here. They're both on the 0 line, so they don't experience any event. But for one, we predicted a probability of 10%, and for the other, 75%. So for the blue one, we are correct, but for the green one, we are predicting the wrong outcome. So we need to quantify how good is good and how bad is bad. So we have to quantify these performances. So we can do this with two families of performances. One is regards discrimination and the other calibration of the model. And I thought to make an analog with this toy. Basically, you can imagine the box as being the ground truth with the shapes. And we can imagine the new patients as the blocks to be classified. And the toddler with his brain being the prediction model, choosing how to make the predictions. So discrimination, you can imagine it as being the ability of the model to assign the block to the correct outcome. Doesn't matter if it fits perfectly or not. While calibration, we can think it as being the ability to maximize the overlap between the blocks and the shapes, independently on if they are assigned correctly or not. So regarding discrimination, we have several families of metrics: rank-based, threshold-dependent, and curve-based. But I will not focus on all of them, just on those that could be more interesting for Tetris. So I start from the area under the curve of the receiver operating curve, called also C statistic. This is the gold standard for classification in binary outcomes, in particular for logistic regression models. So here we have the true positive rate or the sensitivity over the false positive rate, or 1 minus specificity. And the receiver operating curve represents all, basically the interpretation of this curve is the probability if we take one patient that is presented the outcome or the adverse event and another who didn't, the ability, we interpret this as the probability of the model assigning them correctly or ranking them correctly. This is also called rank-based, but also threshold independent, meaning that is not specified for a specific NTCP threshold, but it represents for every point all the possible threshold that we use. Because we could, when we assign a probability, we had to also decide a threshold above which and below which we have an event or not. So if we assign, for instance, 0.5, which is the standard one, we assign, yes, we have an event, as most probable event, or no, the patient will not experience that. However, the area under the curve is a bit problematic for rare events, which is the case for these adverse events in radiotherapy. Then we have the threshold-dependent metrics, still in the second family of discrimination metrics. I put here just the confusion metrics just for completeness, but just to have an idea of what we're talking about. There are many metrics here, like sensitivity, accuracy, prevalence, and so on. But here I reported two that could be useful for Tetris, like the balanced accuracy, which is better than accuracy for events that are rare. So it keeps a balance in the two classes in the consideration. But as the con of not penalizing the positive predictive value and a negative one symmetrically. On the other side, we have a Matthews correlation coefficient that is here and is put here for a reason, because it considers all the good metrics and negative metrics, the green and the red ones, equally. So it's rewarding all the good ones, the true positive rate, true negative rate, and etc., and penalizing the negative ones, like the false negative, false positive rates, etc. And these are probably best for rare events. Now moving to calibration, we have this family that represents the agreement between the expected outcome probabilities that we determine within normal NTCP models and observed toxicity rates that we observe in the patients. So I would remark here that calibration, clinically speaking, is preferred over discrimination because it's more useful in telling the patient what's the actual risk. We tell the patient with what is the absolute risk instead of ranking, telling the patient if he or she is doing better or worse than other patient. And here we have several families of calibration metrics. I divide them in global, local, risk group, and pointwise calibration errors. But here for this presentation, we focus only on the global calibration. So here we have a calibration plot. So it's a visual way of assessing a model. And we have the observed toxicity incidence on the y-axis and the predicted one by the models or the model on the x-axis. the ideal curve would be the one on the diagonal, meaning that all the predicted outcomes correspond to the actual one that we observe in the population. For these models, we analyze also what is the calibration intercept, or also called the calibration in the large, so to see where the curve intercepts the y-axis. Ideally, it should be 0, but could be different from 0, and that would indicate, for instance, a different prevalence of the endpoint in the general population, or in the population of breast cancer patients, for instance, but that are not undergoing radiotherapy in specific Tetris states. Another metric that we observe is the calibration slope, which tells us like what is the capacity of the model, or to what extent it is underestimating or overestimating the true outcome with respect to the ground truth in a different part of the calibration plot. Another metric that represents global calibration is the log loss, or binary cross entropy. It is the inverse of the log likelihood. So for those that are a bit more familiar with statistics, we want this as low as possible. It's a metric that combines both calibration and discrimination, but it's more tending towards calibration in terms of interpretability. And what's important about log loss is that it accounts for the confidence of predictions. So let's say an outcome is no adverse event for a certain patient, but we predicted it to have a 0.9 probability. So the model is clearly wrong because it predicts 1, basically. But we can say it's too wrong in the sense that it's too confident in predicting 1. So these kind of predictions will be highly penalized by this metric. Then we have the Spiegel Hartress score, which is a normalized test statistic. So we want it close to 0 and with a p-value greater than significant values, because that indicates that the model is similar to the best model, which is a well-calibrated model. So a model that is lying on the diagonal of the calibration plot. This quantity, this score, has the ability of detecting calibration biases, but is not useful for comparison or ranking, but only for benchmarking a model. Then we have general descriptors that don't fall into the other categories that I showed. One is the archaic information criterion, and the other is the Bayesian information criterion. They account for both model complexity by indicating the number of parameters in the formula, and the goodness of fit by using the log likelihood here. And similarly for the Bayesian, giving more stress to the number of parameters, especially for large data sets. Yes. Regarding specifically the models in Tetris that I scrutinized, these are the predictor, the performance metrics that have been reported. So you see that the curve is the most reported in most types, most endpoints for secondary cancer, lungs, and heart. However, the vast majority don't report not even one performance metric, which is concerning, especially if we consider that in 2015, there were released the tripod guidelines for reporting summary scores. So here they say how papers should be written and regarding models, and what are the measures for the performances to be reported. Here, for instance, they mention model discrimination, model calibration, and other performance measures. It means that a paragraph indicating this is necessary. So it's strange that many studies don't report them. And then regarding the metrics to be used for the NTCP model selection for Tetris, I just propose that to use the one I presented. So for discrimination, to use the gold standard, which is higher under the curve. and use other metrics that are robust to imbalances. So when we have rare events, like a balanced accuracy and the matrix coverage coefficient. For calibration, instead, we wanted to have a visual assessment, so to have the calibration plot with intercept and slope. It could be useful to have like a bias analysis with the Spiegel-Halter's Z-score, and to have a sense of the model's confidence with the log loss or the expected calibration error, which they show here. And regarding the number of predictors, since we want to match since we want to match models to individual patients, maybe we want to restrict too much the number of predictors, so we wouldn't use the archaic or the Bayesian information criteria. With this, I conclude, and I remain open for questions.
Thank you both Eva and Filippo. That was really clear and comprehensive and interesting. So question time, if you have questions, start raising your hand, and then I think I will give you the floor for your question. Okay, we can start from one question in the chat from Carl Magnus Nilsson. The interaction between organs like the heart and the lung, will that be integrated in the predictive model? Does those to the heart will affect the severity of pulmonary effects? The dose to the model organs, are they converted to EQD2?
Should we take one question at a time, maybe?
Maybe yes. Okay. Yeah. So yes, first, I mean, integration of doses to the heart, and to the lungs.
I can respond to that. So indeed, what we discussed so far was the simplistic assumption that only one organ exposed to radiotherapy would be linked to to a particular endpoint. But sometimes there could be multiple organs that in combination provide a certain function. And then you need to take into account more than one organ at risk. And as we can make multivariable models, which take into account patient-specific factors, we can also, in the multivariable model, include multiple organs of interest and consider separate summary measures of the dose to each of those organs. So that's completely possible, and it has been done.
The second question was on the use of EQD2 to convert, let's say, different fractionation schemes.
Yes, I mean, for in the interest of time, we couldn't cover everything, but absolutely, physical dose is not a complete representation of the damage, but rather we would prefer to convert the dose volume histogram to EQD2 or perhaps BED before performing or fitting the model.
Okay, and then we have many other questions. So the input data and dose distribution that goes into the models, are there different modalities represented, like 3D, CRT, VMAT, and protons, and different fractionation schemes, as the different modalities give different dose distributions and side effects?
Yes, I think that this is related to the generalizability of the model and also perhaps the calibration. Filippo, would you want to give an answer to that?
Yeah, no, based on the models you could find, the vast majority is using photons, conventional 3D CRT with a true grave per fraction. So it could be possible to generalize, but there are just few models where they use a data set with different fractionation, different modalities. So yeah, it's limited to that.
And I would add that these are important aspects to consider when you apply a model to any independent data set or patient case, because it depends. The more similar a case is to the training data set, the more confident you can be that the prediction is valid.
Then there are two other questions. I think I will reply to that. Will the models be available for user clinics to compare radiotherapy plans for patients? This could potentially hint what modality and plans is the better one, thus better quality for patients. And I will underline once more that Tetris' goal is on optimization of follow-up. So we do not aim now to propose models to optimize plans. So this is the main goal of Tetris. Then, of course, models are models, and maybe people can use those in different ways. But in Tetris, we do not aim to push models to optimize treatment. The last question, if a clinic wants to join the collaboration Tetris and add in anonymized data to the models, is that possible? Of course, just contact me. That's easy. Okay, then we have a question from Laia. So if I understood well, you will be applying and comparing existing models. Will you consider developing new ones? Maybe even consider machine learning or deep learning models?
It's a good question. Our aim is to only use our retrospectively collected data our retrospective cohort for testing the models we want to integrate, not develop new models. And it is a challenge to develop models for endpoints that are very rare, and that is the case here. Some of the publications available have models developed on quite a lot larger data sets than we have, but a little bit referring to a previous question, what we can't guarantee is that those models are quite suitable for the types of dose distributions that we have in modern radiotherapy. So what we can do, we think that the best we can do with the data sets we have access to is to test the models and see that our predictions are at least in line with what would be expected. Tetiana, do you want to add something to that?
Yes, again, the idea was to produce models that are robust as validated in new cohorts with new techniques to personalize follow-up. To start from those models for the dose aspects, and then start trying to add other possible personalizing predictors, and that will be maybe new models, but not new from the point of view of the dose. And the first idea is to use the information you can have on images, from images, and there is already something on classifications, and then that will be the topic of the next Tetris webinar in March. And then for the course where we have information from genetics and transcriptomics to add these information, and that will be somehow again new models, but this is what we plan in Tetris. Further, really new development of models using machine learning or deep learning models is not foreseen in Tetris. Then that could be other projects, let's say side projects, postdoctoral project, everything like that, that is not at the moment our main goal. So at the moment we have the project with what, let's say, we have in the grant agreement with the European community. And so those are the main goals. Everything can be added through further projects outside the Tetris, but related, of course, to the dataset. I think Sarah has a direct question.
Yeah, thank you very much to both of you. Very, at least for people that is a bit far from the physical and statistical, is quite educational. Thank you. So I have a question, because if I understood correctly, you are going to select 1 or 2 or 3 the best models, then to apply based on calibration and discrimination metrics. So I was thinking, because you have proposed several metrics, so how will be dealt with, because as much as you have different metrics, the randomly you can have that the different models can have different values. So how do you plan to select? I mean, if it's Matthew correlation is in favor, but not the other AUC is in against, you know? I don't know if you have thought about it.
Filippo, I think it's for you.
Yeah, indeed, it's a good point. Yeah, I don't think it's a black and white situation. I think this ranking of the models first has to be decided, maybe to sit down and decide what are the metrics here, made a proposal, of course. But then to discuss, like, if there is a metric that is more important than others. Surely we're more interested in calibration than discrimination, for instance, but still, that doesn't fully answer. I think we will tend more to do a choice that would be more like a human choice, let's say, based on all the metrics that we see for each model. Then we see if there is let's say, a winner for each endpoint or not, or if we had to use other ways of choosing the right one, or the best one.
Okay. And if I can say the last very quick question, I think if you have several years, over the years, different follow-ups, you're going to apply time event methodology, Cox regression?
Yeah. No, we are planning mostly to apply the most, you're planning mostly for logistic regression, those kind of models. So it will be up to a certain time point after, for instance, 2 years or 10 years, 20 years. Because then we would have to do the same even with survival analysis. As you say, we have to decide at the end a specific time point in order to have the possibility to use metrics and compare them.
Okay.
And it's actually given by the model that we choose to implement, because it's how it was trained.
Exactly. Yeah, I was thinking while I was asking, I respond myself. Yeah, depend on the model. Yes. Okay. Thank you very much.
Perfect.
I do not see any further question. I mean, if you have a late coming question, you can maybe write to me or to Eva and Filippo directly if you want to discuss with them. Thank you so much to you all for being here. That was quite interesting. Next webinar will be in March. I will send you the exact dates. My apologies, I can't remember that now. Have a good afternoon, you all, and really nice to see you. Bye.
Bye-bye.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Bye. Ciao.
Bye bye. Thank you.
Bye.